There are a number of other things that take effect in 2014 that we'll kind of move quickly through. I mentioned the waiting period. There can be no pre-existing condition imposed on anyone. Currently, children under the age of 19 can't have a pre-existing condition. In 2014, it's no one. That has been a point of discussion. You know, if people can play Russian roulette and not be in the system and just come in when they're sick because the plans have to accept them, that's problematic. I think the premise of the law is, you know, people will maintain coverage and not pay the tax, so they'll be in the system. How that bears out is a bit of an issue. I want to focus just for a minute on this issue of the Medicaid question. So to qualify for premium assistance or a cost share, we said that you had to fall between 133% and 400% of the poverty level. Okay? Well, when the law was written, the theory was, or the law was, that you would have Medicaid if you earned up to 133% of the poverty level. Well, what happens if a state doesn't decide to expand their Medicaid? And several states have indicated that at this point they don't intend to. Those people don't qualify for premium assistance, okay, through the exchange. The employer presumably won't be penalized for those people because they don't qualify for premium assistance or a cost share, but those people are still without coverage. So they're still, you know, in the goal of expanding access, they're still going to the emergency rooms to take care of the ear infection because they don't have health coverage. And you know, this is a whole other discussion that many who serve the underserved populations are having now. Even if we expand coverage to this group of people, how do you get to them? You know, how do you let them know that they have coverage and that they can go to these clinics and that kind of thing? So it's a far more complicated issue than meets the eye. Couple issues that have been delayed. One of the things in the law that was created all kinds of stir were some salary-based discrimination rules that would apply to fully insured plans that prohibit providing better benefits to higher paid people. These have been delayed until future guidance is issued. These kinds of rules already apply to self-funded plans. Therefore, employers that want to provide a better executive benefit do it on an insured basis. And that's okay for the moment, but if you do that, just be aware that those rules could change. In 2014, the law includes an automatic enrollment provision for large employers. That has been delayed until future guidance, but I think the premise there is to deal with inertia. You know, it happened on the 401k side, where if you choose, you can automatically enroll people, and if they don't want to be in it, they can opt out. So that's kind of the premise there. A couple of tax provisions that are coming up soon, or some of them have already happened, and so we'll kind of skip those. But there's a new Medicare tax that is imposed on high earners. And from the employer's perspective, what's important is the withholding. The employer portion of the Medicare tax doesn't change. It's only the employee portion for individuals who earn over $250,000. What the employer needs to do, though, is begin withholding once the employee reaches $200,000, which may result in over or under withholding, but that's the individual's responsibility to deal with. What the employer needs to do is make sure that their payroll systems will trigger someone who earns $200,000 and begin doing the increased 0.9% withholding on the employee's share of the Medicare tax. There's also a significant increase in the Medicare tax on unearned income, you know, passive investments and so forth, and that's something just to be aware of, that's coming. There's a tax on manufacturers of goods and supplies of medical equipment. That has created lots of controversy, and few bills have been introduced to repeal that law, but we'll have to see where that goes. So what are some employer opportunities in this new world order? We've talked about the employer shared responsibility for employers who employ 50 or more full-time equivalent employees. the employer will have to look at the marketplace, look at whether it's going to be important to continue to provide benefits for employees. You know, the whole issue or notion of employee benefits began really back in the 20s or 30s, depending on what you want to look at, with employers that had people in the lumber camps and that kind of thing, and they wanted to provide medical benefits. Really began as workers' compensation and then has evolved. In World War II, it really got its stronghold in the employment world because there were freezes on wages, so employers couldn't raise wages, so they negotiated for employee benefits. And so, you know, when you think about it, if the employer does not offer benefits and just decides to pay the tax, the employee loses significantly because of the tax-favored status of employee benefits. It's a significant part of the employee's wage, so if the employer needs to compensate by increasing wages, then that then increases the tax liability and so on and so forth. So it's not, you can't just look at, okay, I'd rather pay $2,000 times all my employees working 30 or more hours per week. You kind of have to look at the bigger picture in making this determination about what you want to do. So that's one thing that employers will need to take a look at. We also don't know what the plans that are going to be offered through the exchange are going to look like. Are they going to be more safety net type plans, or are they going to be the more attractive type plan that employees have learned to love or hate, depending on how you look at it. There are a plethora of cost containment strategies that employers can use. I think you're going to be talking more about some of these, so I won't dwell on them too much, but the notion of wellness. You know, we are not a particularly healthy world when, you know, the obesity rate is whatever it is, and depending on whose statistic you want to read. There are a lot of things that can be done to encourage healthy lifestyles, but since I'm an attorney, I do have to point out the legal concerns that you have to be aware of, and there are some unanswered questions. If you have an outcome-based wellness program, you need to make sure that your incentive meets, there are 5 criteria for an outcome-based wellness program, one of which is that the incentive or disincentive currently can't be more than 20% of the cost of coverage. Healthcare reform will increase that to 30%, and the government has the right to even increase it further. So that's great, but we also have some ADA concerns that we don't have answers to about, you know, what you can do with regard to asking for information or requiring people to meet certain standards. So what's important there is to remember that if you do have an outcome-based wellness program, you need to make a reasonable alternative available to people so that they can get the incentive if it is medically inadvisable for them to do whatever it is that you've asked them to do to achieve whatever that goal is. Big issue with the collection of medical information and whether it's voluntary and whether that's acceptable under the ADA. It'll be really good if we can get guidance on this. But what we can be sure is that there will be challenges. Originally under the ADA, obesity in and of itself wasn't considered a disability. More and more there were some amendments to the ADA, there's now a big question. And particularly because if somebody is morbidly obese, typically they have other conditions that substantially affect a major life function. So those are some of the push-pulls that employers are going to have to deal with as they look at some cost containment opportunities in the wellness arena. The defined contribution opportunity is another way. You know, historically, employers have done what's called a defined benefit approach, where they've just offered a health plan, you pay X, and you get everything that that health plan has to offer. There's a big move, you know, kind of with health savings accounts and health reimbursement accounts and so forth, for employees to have skin in the game, so to speak, and to be less oblivious to what medical care really costs. And I think there are some opportunities in that arena to really address the transparency of healthcare costs, and I think that's the subject of the next discussion. So critically important. You know, it's unfortunate when, you know, somebody asks about the cost of a particular procedure, and the business manager at the office says, oh, nobody's ever asked me that question before. So I think that whole mentality needs to change a little bit. Technology is a huge opportunity in regard to cost containment issues, it seems to me. Just a little example, a few years ago, one of our sons was playing lacrosse and he split his leg open, and I was in a meeting, it was an evening meeting, and wasn't reachable, and there was going to be about a 5-minute period of time when the other boys were going to be alone, and our neighbor was going to be there. So I get home from the meeting several hours later, and our neighbor was there. I thought, Nancy, you were supposed to be here at 5, not 8:30. Anyway, long and short of it was that my husband had to take Jack to the hospital to get stitched up, and so in that process, the emergency room said, well, have you had a tetanus shot recently? And he was 13 or something at the time, and he said, yeah, I think I did a year ago. But of course, my husband had no clue, and they said, well, we're not going to believe a 13-year-old, so he had to get a tetanus shot again. You know, and that's a small example, but if there was a central place to go get that data, I mean, I knew it in my head, but they couldn't get a hold of me. So, you know, magnify that to, you know, as life issue, and you can see where it could be useful to have some central source for medical information. There are a number of opportunities with kind of what are called medical homes, which are not institutions. Like, you know, when you first read it, you think, oh, medical homes, we're going to put everyone in an institution. Rather, they are a program whereby a physician or a medical professional is kind of the I don't want to say gatekeeper, because that has kind of old HMO, PPO type implications, but rather truly the filter and the manager of all the specialists, because medicine is complicated. And so we kind of have two things going. We need patients to become more responsible, more knowledgeable, but they also, you know, we can't expect every citizen to go to medical school and be able to understand everything. So, you know, the medical home model would create that opportunity. I want to leave a couple minutes, sorry, used a lot of time, for any questions.
You mentioned the people going to the emergency room, and what are your thoughts on, you think the government has addressed those illegal or undocumented people who go to the emergency room for medical care, and they're getting medical expenses paid as compared to those of us who do pay tax dollars to get medical coverage?
Yeah, that's a huge philosophical question that is not, I don't know, no, there's no good answer to that. You know, it's a particularly big problem in certain parts of the country. I don't know. I mean, as a humanitarian response, you know, do we have a responsibility to provide emergency coverage to everyone? You know, if it's an emergency, do you have time to even know whether someone's documented or not? So, no, there is no good answer to that one at this point.
Can I ask a question about the small business tax credit? When is that effective?
It is effective. It was effective in 2010. And just quickly, so everyone knows, the small business tax credit is available to employers who employ fewer than 25 employees and whose average wage is less than $50,000. And if the employer pays at least half of the cost of health coverage, the employer can get a tax credit. And it is available now. It's been a bit of a non-starter. The government tried really hard to get the word out about it, but for whatever reason, I think partly because it begins to, the only group that could get the maximum credit are people that have fewer than 10 employees and whose average wage is less than $25,000, and then it's a sliding scale.
Karen.
Thank you so much, Karen. I think I'm always kind of moved, one, by the complexity of the whole issue as I continue to still learn about it myself, and then Karen does a great job not only being able to articulate it, but kind of just each of the nuances she can navigate really easily, and I'm always really impressed by that. Thank you so much, Karen.